Begin with just saying welcome. I'm really glad you're here today. I'm Laura Kolaskowski, the lead patient representative for iConquerMS. I was diagnosed with MS in 2008, and I've been affiliated with this project for quite a few years now. I want to say 7 or 8. We are sponsored today by the Accelerated Cure Project for Multiple Sclerosis, as well as iConquerMS. And iConquerMS, we like to say we are the voice of the people affected by MS. So we're partnering today with a number of people to begin with this Chat for Chat. Chat has offered to do these sessions for us. As a reminder, if you please put your system on mute, that would be great. But I'd like to just quickly review what we've done, some of our big accomplishments this year. We're still continuing with Real MS, which is research engagement about life with MS, and it is a longitudinal study where everyone participates and does a selected series of surveys about their overall health, their MS history, and the neuroqual. And it's a great way to contribute not only your data to a larger database to make a big picture of MS, but it also keeps your data together in one nice compact file that you're able to pull up and look at your records over time as to how your MS is reacting. The current round of Real MS, it is done every 6 months, and the current round closes on December 21st. So I would encourage you, if you haven't done your recent surveys, hop on right away and get it done before you get caught up in the rest of the holiday hubbub. If you've not begun participating in Real MS, it's never too late to start. So join us at iConquerMS. One of the benefits of being a part of this cohort is it gives us information about you so that when we're looking for people to populate ad hoc committees that are looking at focus groups or councils, priorities, study design, execution of studies, we have a database of people we can go to and say, would you be interested in participating in this? So, but we have to know where to find you. So please join us with your information. Another project that kicked off really well this year was Our Questions Have Power, which is participant-driven research. And the people who participate in iConquerMS are able to propose questions that would be meaningful to us. And those questions then are rated, evaluated, and voted on by the community. And we are looking then to match researchers with research questions that are important to us. And I can't emphasize that enough because I've not had any researchers say, what do you want us to research about MS? But I sure have lots of questions, and I'm sure you do too. So that's one of the benefits also of joining us at iConquerMS. And this is again through our portal at iConquerMS.org. Today, you're going to hear more about our COVID-19 studies and the work that we've done there. And I'm really excited and proud of this work with CoverMS because it's really a patient-facing database and collection of information. Yeah, there's lots of COVID studies going on, but they're all research initiated. And our study is participant initiated. And as we hear more from our speaker today, you'll learn a great deal more about what those results look like. If you've joined this study, I really want to prompt you to remember to log on if you have received additional vaccines or the boosters, or even if you have not participated in the vaccination. We want to know that because, again, that helps to make the big picture. If you haven't joined us yet for the COVID study online, again, you can do it at iConquerMS.org, and it's not too late to join us. And finally, I'd just like to say we have some really exciting things coming up in the year ahead. I'm particularly proud of the work that we launched with the MS Minority Research Engagement Initiative. And we've really expanded this, and we have a new person that's come on board with the Accelerated Cure Project to help us coordinate the RIDE Council. RIDE stands for Research, Inclusion, Diversity, and Equity. Those members of the council are being populated now, so watch for announcements about the launch of our RIDE Council. We're deep into the work on the Pediatric Network and the Care Partner Initiative. Both of those are important parts of the population of people affected by MS. Pediatric because children are not represented and their voice really needs to be heard. and the Care Partner Initiative, because we all have people who help make our lives better, who also could use the support and would like to have input into what's going on in MS research. So look for these things coming up next year, because I'm really excited how we've grown this initiative of iConquerMS. I'm going to turn over to Chat now, so we can really jump into why you're here. I know you didn't come on to hear me talk about iConquerMS. You're here to learn about research and COVID-19. So Chat, I'll turn this over to you. And thank you again, everyone, for joining us. And don't forget, mute your microphones.
Thank you so much, Laura, for the introduction for the iConquerMS. Obviously, that the community have done a lot. So, and again, welcome everyone to our webinar today. Just for those of you who are new, and this is actually not our first time for Chat with Chat. It just happened because my name is Surachat, and I go by Chat, so that's why it's Chat with Chat. So it's kind of confusing, I know, but this is not the name that I got, but we got it from our community. So, but anyway, today I'm excited. We're going to discuss about the COVID-19 and MS, and the topic is actually the lesson learned from iConquerMS, and I'm really delighted to kind of introduce our guest speaker today, Dr. Farrah Mateen. So I'm going to call her Dr. Mateen, and she's she's from Saskatchewan. I need to kind of excuse myself if I pronounce that incorrectly. She's originally from Canada, and she received her medical degree from there in 2005. And later on, she kind of slightly moving down south to Minnesota. So she got her neurology training in Mayo Clinic, again in Minnesota in 2009, and finished her fellowship in medical ethics at Harvard University in 2008. And later on, her clinical and also research fellowship training in neuroimmunology and also neurological infections at Johns Hopkins Hospital in 2012. And she completed her doctoral studies as well. So she got, in other words, she got MD, and also she got a PhD in the international health at Johns Hopkins in 2014. And currently, she is an associate professor of neurology at Harvard Medical School. But before we move forward to her presentation, I kind of like to take this opportunity to introduce Holly Schmidt, and she is a vice president of the scientific operations for the Accelerated Care Project, and she has some background information to share with us briefly. Holly, let's go to you.
Thank you very much. I need to share a file. So let me see if I can do that. Share screen, great. Here we go. Okay, hopefully people can see that. So thanks for having me on, Chad. I wanted to just give a little bit of a plug for a program we have going on that Laura mentioned, as well as a note of appreciation for people who have participated in this program. And the program I'm talking about is the Our Questions Have Power program. This is the program that Laura commented on, where you can share your research questions, and we will take a look at those within iConquerMS, and we will share those questions with researchers, and we will also see what we can do to get answers to those questions. And when we launched this back earlier this year, we launched it with a focus on COVID-19 and MS. So we really wanted to know what the community of iConquerMS members wanted to learn about the effects of COVID-19 on themselves as a person with MS. So we launched that. We had a lot of questions submitted. We asked people to vote on other people's ideas as well and comment on those. So we have, really rich dialogue about what these questions mean to people. And we are now working with those questions. And so I wanted to share a little bit about how some of those questions have come forward in our work and our work with our colleagues. And In case you weren't aware of this program yet, it's really easy to get to. You just log into iConquerMS, go to your dashboard, and you'll see these top two buttons. You can vote and comment on other people's questions, or you can propose your own question. So that's how to do it. If you go to vote and comment on other people's questions, then you will see this kind of page. It's got some explanation at the top, and then you can see, you can sort the questions and you can read and comment and so on. So that's what that looks like. And then if you want to propose your own question, which we highly encourage you to do, then you click that other button, and that will give you a little bit of background and ask you to type in your question and any other information you'd like to add. And like I said, we originally launched this asking for people's questions about COVID. We've now added a new topic, which is MS symptoms and their management and treatment. So go and look at the questions that people have proposed and think of your own. But we're also still collecting questions about COVID as well, because we're still in the middle of it, unfortunately. So there will continue to be more questions, and we'd like to know what those are so we can help them get answers. I wanted to show sort of what we've done with the questions that have been submitted so far, and to talk about some of the progress that's being made. So this is one of the questions that came in. Are symptoms from the vaccination stronger among MS sufferers? And so that was a really good question. And I'm happy to say that this question has been answered. We do have an answer to this question. Through iConquerMS, through the CoverMS study, which Laura mentioned, which is asking people with MS to tell us about their vaccination experience and their overall COVID-19 experience. And we analyzed the data, what people told us about how they felt after their vaccinations, the symptoms, the side effects, were they mild, severe, in the middle, and analyzed all that data to find that actually, no, the symptoms are not stronger among people with MS. They're very similar to what was reported in the clinical trials for the vaccines. So that is an answer to this question, and we'll continue following this over time. The boosters are now being taken, and so there might be a different answer down the road, but at least for the time being, the symptoms are the same, and that should hopefully provide some reassurance to people about getting vaccinated. There are a number of questions that we're working on currently with the CoverMS study about vaccination. For example, how well do the different vaccines work in people with MS? Would extra boosters be helpful if you don't have a high antibody response? Does the effectiveness of the vaccines differ based on how long you've been treated with a B-cell depleting drug? So the data we're collecting in CoverMS can help us answer these kinds of questions. So we'll be looking to do further analyses in the future. We also have questions about the impact of vaccines on symptoms. Can the vaccines make symptoms better? Can they make symptoms worse, or can they reactivate symptoms? So because we're collecting information not only about when people are vaccinated and which vaccines they're getting, but we're also asking people to report on their MS symptoms, we can put those data together and see if we can answer these questions as well. We have information also from other COVID-19 studies. Farrah Mateen, who will be talking in a moment, worked with us on some COVID-19 impact surveys. And some of the things we asked about were, has it changed what people are doing in terms of disease-modifying therapies? Or how has it altered any other aspects of management and care? Have people had to delay MRIs, for example? So Dr. Mateen has published some data from these studies, and I'm sure she'll be talking about that, so I don't want to scoop what she's going to say. But all of the data that iConquerMS members have contributed have added to our knowledge about COVID-19 and MS. And then finally, here are a couple of other questions that Dr. Mateen and her staff have helped analyze. Has COVID-19 isolation affect people with MS? And has the COVID-19 era resulted in any positive changes, for example, through increased access to telehealth? So this is just to say that we are taking a good look at the questions that are submitted. We are doing our best to make sure we, to the best of our ability, can help answer those questions. And other questions that are a bit beyond iConquerMS, then we will field out to other researchers. So just again, Here's the dashboard. Please take a look at those top two buttons. And then I should also put a star next to the third button, which is participate in the COVID-19 vaccination study. That is CoverMS, and that's where you can tell us about your COVID-19 vaccination experience and help us learn more about the benefits of the vaccine on people with MS. So I will stop sharing now and hand the podium over to Farrah.
Great. Well, thanks, Holly. That's really it's interesting to see how closely matched the questions are to the presentation I'm about to give. So just going to see if I can share my PowerPoint with you. Let me see. I would like to record this computer screen. Okay, I'll let them do that. Let's see if you can. I'm not sure if it's going to give me permission to share. Do you have the option to share my?
Try again, Farrah.
Okay. I'll try it one more time.
Yep. If you cannot, I can do that as well.
Yeah, I think I need to open my system preferences. So that might not be that easy.
You want me to share?
Yeah, if you don't mind, that might be easier. Thanks. Otherwise, I can switch computers, but that wouldn't be that fast. So thank you.
All right.
And if you go to slideshow, it can start.
Okay.
And you can, yeah, that works perfectly. Or you can even go to actually showing the.
What do you see right now? I think.
Yeah, it's fine. That's fine as is. Yeah, it's okay.
Hold on a second.
As I say, you could show the audience view.
Right. Yep.
I think.
We try to do that.
And then slideshow, I think.
Yeah, I have two screens. I know that's gonna be the problem. Let me.
That's okay.
No. Oh, now I lose my slide. Hold on. It's a technical problem.
So maybe while you're doing that, I can just start by saying I'm really pleased to be able to speak today. And as mentioned, I'm a neurologist at Mass General, and I've worked with iConquerMS over the last approximately 2 years now. And what I'm going to show you are results from the original COVID MS surveys. So these are coming from, surprisingly, almost 2 years ago that we started the COVID pandemic. And so we basically interviewed, or we surveyed more than 1,000 people for these studies. So that's perfect chat. If you go up one slide, that'll get us to the top. And the opposite way. All right. Okay. Thank you. So now you're on slide duty. Sorry about that. But so as mentioned, we're going to talk about lessons learned. So I think that this study happened sufficiently long ago that we can actually think about trends and evolution over time. So next slide. So as people know, just to remind everyone that MS is a relatively common condition. Sometimes people don't tell other people they have MS, but there's more than 700,000 people with MS living in the USA and approximately 100,000 in Canada. And immunosuppression has really come into play here. So immunosuppression is really central to a lot of how we treat MS because we consider it an autoimmune disease, and high efficacy therapies are increasingly common now. However, immunosuppression is a recognized risk factor for getting COVID-19 and prognosis in COVID-19 and some of the other factors like timing of vaccination from a health policy standpoint. Now, CDC, for example, may not be thinking of MS immunosuppression per se. They may be thinking of chemotherapy or transplant patients. but MS patients can be considered immunosuppressed. And so this is actually a question we've got, am I immunosuppressed? So we've experienced that. Everybody knows that we've been dealing with this for quite some time now, and that COVID-19 is not just a virus. It's actually become a social, economic, and political sort of policy experiment. And we're seeing that there are certain groups that were already disadvantaged may have had a disproportionate effect. So we know that, for example, mortality in COVID has been different among different groups. All right, thank you. Next slide. So people on this call will know that COVID-19 has, even if you didn't get COVID-19, or maybe no one in your family had COVID-19, it has changed your life, may have changed your health behaviors, and everybody at some point was basically under a lockdown. And so that has impacts on people with MS. Certainly disrupted employment, social gatherings, even social interactions in general, a sense of social support and isolation, and then access to public services, like in Boston, where I live, bus schedules, train schedules, etc. So at the time of this study, which we began in very early, I have to say, it was really a rapid onset. That was thanks to the iConquerMS community, who was poised to answer questions almost in real time. So we didn't have to create a cohort. We were able to ask these salient questions right when they were happening, rather than having to start from scratch and figure out who we're going to ask. So, so we're able to implement pretty quickly. Next slide. So the goal of this survey was to look at folks with people with MS and to ask them, what is the impact of COVID-19? And we wanted their perspective, not just to hear what was going wrong, but to hear how things could be improved. So unmet needs, and then also what were the questions people wanted answers to. So at that moment, everybody had a lot of questions, but what were the dominant questions, and what were the things that were really sort of more pervasive in terms of things that were worrying people? We also wanted to ask, what is sort of the mental health and psychology around COVID at that time? Yep. So at that time, we created a new survey instrument, and it was designed by the authors. We have several iConquerMS and Accelerated Cure Project members, as well as a team of me and other research staff, who were able to come up with a kind of a battery of questions, if you will, and try to highlight specific themes. So at that time, awareness, what was your experience? And then specific to MS, how did your healthcare change? So what about your disease modifying therapy? How did your treatment get delayed or paused? And how did you choose to interact with the healthcare system at that moment? But also more broad things like employment, hours, access to food and exercise. And so our final sample size was 1,019 participants. And this is just a heat map, not by temperature, but by respondents, of where people were actually coming from. And really, really pleased to say really good representation across almost all US states. Some states more densely populated than others, and other states, we continue to want more participants everywhere, of course, but we did have really good representation. And I think that's really unique in the sense that we can say that at that moment, whether you had a neurologist, whether you were seen in an academic center or a private practice, whether you decided to have any interaction at all, that you were part of as somebody had mentioned, the bigger picture. And so that we wanted to hear from everybody who is experiencing the situation, not just people who are seen in a certain place. Next slide. So in this case, we had, as mentioned, over 1,000 respondents. We had an average age of 54 years, ranging from age 20 to 81. Majority were white and female, and were diagnosed with relapsing remitting MS. And at that time, the modal household income was $50,000 to $100,000 per year. Most people had a highest level of education of a bachelor's degree or above. 39% employed, 39% disabled, 12% retired, and 4% unemployed. And that was all self-declared. Next slide. So in terms of people who were reporting how they were doing, we used the PDDS, which is a patient-derived disability status. So people tell us how they're doing, and it's been validated in many studies to use that type of score. It turns out to be very accurate. And we basically had a fairly a moderate level of disability in people under 55, and then early cane and over 55. And then the most common comorbidity reported was depression, then hypertension, asthma, heart disease, and diabetes. And I've just mentioned some of these because they're either collinear with COVID, so that they may have like interplays with it, or they may be risk factors like asthma or hypertension or heart disease. So increasingly, we're starting to think about MS and comorbidities. We asked folks how many people are treated with a disease-modifying therapy. A majority of people are treated and taking a DMT. A small fraction of people had a relapse within the past month, under 10% though. And then 5% under 55 were hospitalized due to MS in the year preceding the survey, 3% over 55. However, about a third of patients and people in this survey had reported that they'd ever been hospitalized with MS. Thank you. So this just tells you sort of the DMTs. I know some of the questions that people have in mind are DMT related. So just mention that the DMTs here are really fairly heterogeneous. We're seeing, probably about a quarter of patients on B-cell therapies of some sort, maybe a little bit closer to a third. And, a good fraction of people on high efficacy therapy, but really a smattering, if you will, of all the available DMTs for the most part. And that just gives you a kind of a landscape of who's participating. Just to mention, a lot of folks had a history of a COVID symptom. Didn't mean they necessarily had COVID. We asked this survey early enough along that not everyone had access to testing. So I think things have changed over the last year or two, that COVID testing has certainly scaled up. But at the time of the survey, about 39% knew somebody who was exposed to COVID, and 4% reported being personally exposed. And I suspect over time this has gone up. People who had been personally exposed to COVID were younger than those who had not. And there's a lot of reasons that you might speculate, for example, being more in the workforce, or having children who are going to school, or other risk factors. People who knew, particularly early on, someone who was exposed to COVID-19 were more likely to stop participating in their overall neurology care. So if you had a personal experience with COVID early on, pre-vaccination, you're more likely to cancel neurology visits, MRIs, any medical visit, and laboratory evaluation. So the level of caution was higher. Next slide. At that time, most participants had not been tested for COVID-19. Some people wanted to be, but couldn't. And I think that was interesting to say that there was an unmet need, and that people did have interest and they wanted the knowledge of whether they had it or not. And then some people just really couldn't get the test. And that really came out in different ways during this survey, both in terms of direct questions, as well as people saying that some people thought they may have had it, so they didn't even want to leave their house to get the test. So I think the science has actually evolved quite a bit in the last year, but some of those early unmet needs were very clear in terms of just, do you have it or do you not have it? This was interesting to me. It basically said, where do people get their information? So how can we provide proper knowledge to people? Where should we be reaching people through? And TV remains the sort of majority source of information, TV news in particular. And then internet sites such as don't want to say proper papers, but certain newspapers that are at least national and have good reporting, like New York Times, they would have a major source of information for patients. And then also some of the national or state level government websites, they're reaching about half of people who replied. And social media is definitely part of the picture. In this case, 24% Facebook, 9% Twitter, and 2% Reddit. Okay. So we asked people how much are they aware of what's happening. in terms of COVID-19. And we found that the confidence in guidelines and for people who were considered immunocompromised or immunosuppressed was pretty high, and that they did know what to do based on what they're told. I think one of the issues that we learned is that people just weren't told enough and that the information just wasn't there early on. So there was less confidence on MS specific information. So people may be very astute in terms of what's going on, but how do you get tested? What, and particularly early, would the vaccine be safe? Would they tolerate it well, et cetera? So how do we get more MS channels of information open? Next slide. So comfort with healthcare seeking information. So the green is kind of things that people were more likely to do, and the yellow were things that people were less likely to do that were like of significant gravity. So people were more likely to drive a car if they could, less likely to take public transit, less likely to go for anything routine, and less likely if you were sick to actually go to the hospital, and more likely to sort of postpone and get rid of anything routine. So any healthcare that was sort of normal, if you will, got kind of pushed away, and really even going to the hospital if you were sick was starting to become less popular. So what we're seeing now potentially is like more of a compression of morbidity. So people who are kind of re-entering the healthcare system may have a little bit more to talk about. Okay. Thank you. So these are comparisons by gender. So female is blue, male is green, and we looked at basically 7 different attitude or belief factors, and we looked at them by gender. Now, some cases it didn't matter if you're male or female. So actually, somewhat surprisingly, impact on personal finances was generally similar between male and female respondents. However, in some cases, women basically had a higher level of impact. So women reported a more negative impact on their diet. Whereas men reported overall that they're more comfortable going to the hospital for an emergency and more comfortable going to the hospital for an infusion. So basically the negative impact was a little bit more noticeable on women from diet, exercise, and worry, whereas men felt in general a little more comfortable. Next slide. So this is one question directly asked by the Our Questions Have Power program. And I think it's actually fairly illustrative how many folks decided to postpone or cancel what we consider to be our highest standard of care. So a neurologist visit, 21%, so 1 in 5 participants, even early on, had canceled an appointment with their neurologist. 1 in 5 approximately canceled their lab tests, which we know can be very critical for safety monitoring. 50% canceled other medical visits, so maybe they prioritize some things over others. And 11%, which is 1 in 10, obviously, almost canceled an MRI. And MRIs are really, for most people, really important to know if your DMT is doing everything it should be. So you can see how people had sort of scaled back on their interactions with their neurological care. Next slide. This is another question that came out of the Our Questions Have Power program, and this continues to be an evolving story. So the story is definitely not completed, but at that time, 10% of participants reported making a change to their DMT dose or their dosing schedule. Most of the time, people were delaying a dose, but only a quarter of the time did they actually seek their neurologist's input. So 74% of the people who had made a change just did it on their own. The most common DMT change was the B-cell therapy class, so ocrelizumab being the most commonly prescribed in that group, in this cohort, really more commonly delaying or pausing that dose. And that matches my clinical experience as well, that there's a lot of questions and remain questions around B-cell therapies. Okay, next slide. This is showing other aspects of what we consider to be sort of a high quality care. So what about other delays and difficulties? I would just say that if there was a delay or difficulty, it's not necessarily the patient, him or herself, chose not to go all the time. It may be the case that the infusion center was closed, or the lab was understaffed, or the hours changed, or certain sites were no longer available or open. So this is not in any way providing judgment on why that didn't happen, but just to say that that didn't happen. Getting a DMT prescription filled, which is of course essential. 2% of people reported difficulties or delays, 4% on an infusion, 6% getting a DMT monitored or safety testing, 22% reported difficulty accessing what we consider complementary services. For example, maybe Botox in that case, or going to a therapy. Obtaining medical equipment, 2%, medical procedures performed 18%, and then accessing their non-DMT medication, 7%. So even though sometimes small numbers, each person in that case could certainly be potentially harmed. And so you can imagine if you have one or two of those happening in one person, that this could certainly add up. Next slide. So just mention telehealth. I think that's really been one of the other lessons learned in MS is that we do have sort of acceleration of adoption of virtual health. And for many folks, that may have been something they had considered or dabbled in, but it wasn't a critical component of their care. And more recently, I know my clinic had during the pandemic gone to about 90% virtual. And we still have a lot of folks who continue virtually and prefer that as a method of interacting. So digitalization has certainly taken off. And some of the things in the clinical community, even how do we standardize our neurological evaluation? For example, we don't get as a good of an evaluation of folks walking, or certain tests that we need to interact, or maybe the cognitive testing needs to be rethought. There's also a digital divide in this country where certain patients may have no problem shifting their care, whereas other folks may have had disadvantages. And so understanding barriers to care in terms of, computers, broadband, even just computer literacy is another way to think about how we can move forward for people with MS. And just to mention, early on, about 40% of folks had a telehealth visit. I suspect that this has only gone up over time. Next slide. We asked about personal lifestyle. So these are self-reported outcomes. And I did kind of allude to this earlier, but women more than men reported a negative impact of COVID-19 on diet and exercise, and men overall were less worried about COVID-19 than women. Also, we did have a subgroup analysis of our white respondents, our Caucasian, and our non-white respondents. And the non-white respondents reported that COVID-19 presented a significantly greater danger to their health than white respondents. That was statistically significant. And there's probably some truth to it. Basically, that if you were from a non-white background, your risk of COVID-19 and dying from COVID-19 was actually higher, whether you had MS or not, particularly early in the pandemic. Okay, next slide. Self-quarantining. Some people have probably been very familiar with this on the call, but a lot of folks had self-quarantined with MS just due to severe uncertainty and kind of not taking any chances. Those people who self-quarantined reported that it was having a more negative effect on their overall health and lifestyle in terms of finance, exercise, and diet. And so people were being really careful, but it wasn't without consequences for many. Next slide. Socioeconomic impact. So we mentioned this, that 40% had a negative impact on their ability to exercise, diet, food. And in general, people who experienced COVID-19, they had people who had COVID-19 had more depressive and anxiety symptoms. So at that time, there wasn't a high number with COVID-19, but those people who did generally had worse mental health outcomes as well. Next slide. We looked at a subset of people, and these data come from a little bit later in the pandemic. So they came from December of 2020 through February of 2021. So you looked at a very nuanced detail in terms of depression, anxiety, and overall general mental health. And these are all published and open access, so I won't go through all the nitty gritty, but basically 27% of people with MS endorsed moderate to severe depressive symptoms. 15% endorsed moderate to severe anxiety symptoms, and 55% endorsed fair or poor mental health. So as the pandemic continued to sort of tear through American society and globally, and the uncertainties that came around the turn of the last year, a lot of folks, these mostly didn't have COVID. So maybe a small fraction of patients, under 5%, actually had COVID. Just being in the pandemic itself was enough to, be associated with some of these poor mental health outcomes. And there are also, of course, folks who may have had depressive and anxiety symptoms beforehand. So this is not a causation analysis, but I would just mention that, we hope to follow this over time and get a more clear longitudinal analysis just to sort of tease out what may be risk factors versus just contemporaneous issues. Next. All right, so this is just showing you the analysis, but there's certain risk factors for worse mental health outcomes and more mood symptoms, i.e. depression, being younger, female, and having more social determinants of health, and we can get into those in the questions, but and then higher functional disability. Those are all associated with worse mental health. Next. I was very interested in employment. So I think that we know that people with MS may already have challenges in terms of employment, thinking about whether to disclose their diagnosis, to whom should they disclose, when should they disclose, how will that affect their health insurance, et cetera, et cetera, et cetera. So people with MS may be more likely to get laid off or let go when times are tough. So we wanted to understand, and that's been shown well before the pandemic and around the world. So what does COVID-19 do to this already challenged situation? A lot of folks were working from home. 37% of people had changes in their employment, often reduced hours, but a fraction of people lost their jobs, which is, obviously during the pandemic led to a lot of economic uncertainties. Next slide. So just to conclude, these are kind of the major takeaways that I have, but I think that there are plenty of them sort of within the details as well. Less than 1% of our participants had COVID-19 when we first did the survey. It's certainly gone up, but it's still a small percentage of all respondents. It's probably still 5%. And so in spite of all that, COVID-19 has impacted the sort of global experience of health behaviors, access to MS care, DMT use, and employment and work, and all aspects of sort of social life. And by April 2020, which was again early, 10% of respondents reported making a change to their DMT, most commonly ocrelizumab. And a quarter of folks did that really on their own. They kind of took the decision making and said, they're not going to do what they were already doing or what they had kind of decided to do before the pandemic. So I think that was very illustrative that when circumstances change, people will make fairly rapid decisions. Next slide. So just to wrap up, I think lessons for future MS care in the setting of interruptions to care. So, they always talk about building back better and how can you understand COVID-19 as an example for, future pandemics. So it's possible this will not be the only pandemic. Hopefully it was, but we can understand interruptions to care more broadly in terms of other, social and policy changes. What we need to think about, where can care be safely received, even when there are difficulties, who should be providing it, which facilities are sort of essential and should remain available and accessible. And I spent some time working with WHO on essential services. And so in many countries, neurology was in general not considered essential. So ICU was essential, emergency departments were essential, and neurologists got redeployed. So if neurology wasn't considered an essential service, it actually got shortchanged pretty quickly. Testing for COVID-19, I don't think that's a done deal. I think people still have interest in testing and now testing for antibodies. Telemedicine and what its role is and how much it can replace versus supplement care remains open. It certainly has made things a lot easier in a lot of cases, but it may not be a full replacement for what we've already been doing. And how do you communicate concerns about DMTs without discontinuing? And that's kind of both sides of the coin here. Where are the best sources of information? How quickly do people need them? My experience has been people have been really ahead of the curve. So science is catching up with the questions being asked. And then how do advocacy and innovations play a role? So, this webinar is part of it, but certain things really should have been done at the beginning before COVID. And how do we kind of implement innovation and advocacy? And some of these things may be home-based testing and home-based care for certain things that may have previously been thought to be too expensive or difficult. All right, next slide. So just to mention that these are cohorts of convenience. So we don't have strong inclusion or exclusion. We're asking people to participate like the people here to share openly and anonymously their data, but we haven't verified in each individual case the diagnosis or looked at MRIs, et cetera. So response rate is about 20% overall of the people who were eligible to reply. And this is a first cross-sectional analysis. So the goal is to do multiple cross-sectional analyses and to paint a picture over time, so to give you the evolving story. But at the beginning, because it was new, this was a one-time snapshot of what was going on in a small epoch of time. And last slide. This is just to acknowledge the folks who are part of the research team. Andre, Shaheen, and Dylan. Also, some of this work was done by a graduate student of mine named Lauren who's going to be a neurologist. So we're excited about bringing the next generation of neurologists onto the platform and to have them understand MS really early in their training, so they can hopefully be the future neurologists and advocates. Company ZoomRx, they were helpful for actually helping with some of our survey design. Particularly, we compared this to providers. And so I didn't show these data today, but while we were asking people with MS their impressions, we also asked a group of 250 neurologists about their impressions. We tried to compare them in parallel. So those are all available for people who are interested. And to mention that some of this was supported very early on by Biogen through an unrestricted educational grant that helped our team do some of the data analysis. When the whole world was kind of shooken up for research funding, we were able to get some funding to redirect our questions. Okay, and then the final is just our research group website and my email. And I think that's it from me. So open it to questions. Thanks for changing the slides, Chad. That was extra duty for you. Thanks so much.
Oh, not a problem at all. I love to. So at this point, I don't see anyone type any question in the chat, but I would really like to encourage, all the audiences today to unmute yourself if you have questions and just speak out your question. Anyone would like to start? Normally, the first question is kind of hard, but any question from the audience? Otherwise, I can go first. I got a list of questions here. Well, maybe I should go first. Farrah. I'm just kind of curious, your research is very interesting. You kind of, portray, the background, as you said, more like a cross-sectional, landscape of what has been going on, early on. So, and I'm not trying to be pessimistic or anything, but as you said in your last couple of slides that, we may have some kind of pandemic before, or another another kind of variant. Would you anticipate the same or different picture, from your study if we experiencing some kind of another wave or anything like that?
Yeah, I think that this, we had never had a pandemic of this magnitude, just to say the obvious. So there was SARS-1, right? And that was about 15 years previous, but it didn't have the national impact or the global impact. And also our medications have changed, right? So the medications we were giving in 2004, 2005 were not of the immunosuppressive degree for the most part, and they weren't as widely prescribed as they are now. So I think in some ways people are more comfortable with uncertainty, whereas we didn't have to be as comfortable with uncertainty before. But it's also like clarified or sort of crystallized where are good sources of information and where can you go that's providing more real-time sourcing of data. So, in our clinic, one of the things we realized is having a general response to sort of preempt some of the questions that may be asked is helpful, especially since our staff was getting redeployed and people were very busy. But then at the same time, recognizing there's nuance to every situation. And so there were times when the general answer was appropriate, but there are also times when you had to modify that response because of people's disease state. So I'm hoping that the sources of trust remain trustworthy. And if there are ever other problems in the future, people would be more like aware of where to go and who to ask and comfortable with asking versus just stopping a medicine, for example.
Mm-hmm. Mm-hmm. Good. All right. I see somebody raised his hand. Rich. Yep.
Hi, Chad. How are you doing?
Very good. How are you? Go ahead.
Good. Hi, doctor. Good afternoon. Thank you for the Dog and Pony Show. I have a question. Do you think in your slides you said that a lot of people moved away from Ocrevus during this? Do you believe that that's because that's the drug that's the biggest B cell depleter?
Yeah, I think the biggest issue was that people paused. So especially, it's a good question. So one of the things that we noticed was there's early uncertainty around B cell therapies and whether people should pause it, delay the dosing, stop it altogether. So as you mentioned, it's the most commonly prescribed DMT in this cohort. So if it was the most commonly paused one, that kind of goes part and parcel with its prevalence. But nowadays, the questions are also around vaccination. And so we know that people on B cell therapies don't get a good immunogenic response from the vaccine, certainly compared to some of the other DMTs or the general population. So that has to be very closely watched. Some people, everybody's different, like I was mentioning, but some people will extend the interval of their dosing so that they may let their B cells slightly repopulate, get the vaccine, and then restart. That may or may not be a good choice for each person. Some people have done exactly what they've always done, but then got a third dose, which is very common. So not just a booster, but a proper third dose. Other people have reevaluated and said, well, because of their particular risk or, the efficacy, we always think about efficacy, safety, tolerability, quality of life. Those are the kind of the main drivers. And if people are taking a drug that they weren't sure they wanted to be on to begin with, that may have led to a reevaluation of it. But yeah, I think the B cell therapies are the ones to be, careful with. Of all the DMTs, they're also very effective drugs. So it's kind of just being, vigilant of what you're getting.
Yeah, it's a catch-22. If you have one that's working for you, like I'm on Ocrevus and I stayed on it. I'm at Mass General in every February and every August.
Yeah, so you've got so that's a good point. You've got a schedule, it's worked for you. And in your case, the benefits sound to outweigh the risks. And a lot at the time, people weren't sure what does COVID look like on this drug? Now we have clinical experience. There's also some mitigating factors like the antibody drug and other things that people, maybe the antiviral will be approved within the next few weeks. So I think the times are changing, but particularly early on, I think it was a real question about, timing, dosing, all those things. But, when you have something that's working for you, it's very hard to justify just stopping it. Because of a potential other risk, because there's the real risk and then there's the potential risk, and the real risk for many people with MS is the MS getting worse. So we have to keep that as a primary consideration.
All right.
Thank you.
Yeah, we probably have time for one more short question. So anybody would like to ask the question? All right. Otherwise, I have one quick question, Farrah. Just very curious. You in your slide, your cutoff between two groups is 55 years old.
Yeah.
So if I were the patient, so just kind of wondering why would you use 55 as a cutoff? That be any reason behind that?
Yeah, I think there are two reasons. One was sort of to find something close to the median of the data set. So just to make a purely sort of graphical decision. We didn't show you some of the mechanics of doing the data analysis, which are not super exciting. But after you graph the cohort, you kind of get a sense of where the median is. So that was slightly above the median. But a more classic answer would be that MS clinical trials, their cutoff for enrollment, which is arbitrary but has been very consistent over several years now, is 55. So things like the OPERA trial, for example, the ocrelizumab trial, that only enrolled people up until the age of 55. And after that, we're in a more data-free zone. So one might argue that if you have sort of randomized controlled trial, evidence-based, decision-making age 55 and under, and over 55, there's a little more extrapolation, shall we say.
Yep. Hey, Laura, I see your hand. Yep, go ahead.
One of the things we talk about all the time with iConquerMS is we're trying to impact care, the path to impact. So I'd like to know if Dr. Mateen found anything in the survey results that she can immediately apply to her own practice in treating MS patients, and if it's impacted you in any way.
Yeah, no, that's a great question, Laura. So thanks for that. I think that there's been some literature prior to COVID that said that neurologists overestimate people's adherence. So we like to think that that things are going well when we don't hear about them. But I think the truth is it can be going really well or not so well, and that neurologists are not always the best judge of what's going on. So, sometimes I think about, we didn't see somebody in a year, and we want to follow up on them. I've been certainly, increasingly proactive on, if we haven't heard from someone, trying to have our team reach out and figure out, are things going well? Are they not going well? Those labs didn't get done. Is that because they got done closer to home? Did they move during the pandemic, or actually are they not feeling so well? And this is a way to sort of reconnect. But through this work, we tried to come up with something that could be usable again. So we came up with like a cascade of care. So we got originally a lot of survey data, but how do you paint the picture? What are the steps towards really good MS care? What are those core data pieces or core components of high quality care? And that has been sort of teased out, but not really well teased out. And just trying to figure out, is it access to medicine? Is it timely prescribing? Is it physical therapy? What is that cascade of care? And how do people kind of stay on or not stay on that cascade? And, where does more policy work need to be done? So I think all of that can have more implications over time, even past COVID, because we know that people don't get perfect care, and for all sorts of reasons. It has nothing to do with COVID. So I think that, we can use those sort of schemata, I guess, and try to push the pedal a little bit further clinically as well.
All right. Well, I can see that we are running out of time. So I'd like to take this opportunity to thank Dr. Mateen for her time to, to spend with us today and also kind of share her very interesting research with us. And before we adjourn, I have a couple of announcements. Before I forget, I kind of like to thank the iConquerMS for organizing this event. There are several people behind the scene, and I couldn't name them all because of the sake of time. But I just like to let everyone know this session has been recorded, and after this, we're going to make it available on YouTube, and I believe that it's going to be information will be sent out or on the iConquerMS website, and we will continue doing the chat with chat again, and we haven't determined the next date yet, but stay tuned and we will email or kind of distribute the news and what about the topic that we're going to talk about next. So please keep an eye on that. So that's pretty much I have, and I like to take this opportunity to wish everyone have happy holidays. Thank you for being here.